Rosacea.
Yeah.
Hello, Doctor. Why have we started yet?
Yeah, we're just about to start.
Okay, so it's streaming, is it?
Mm-hmm.
Okay, so can you please talk to me what you're gonna talk to us about today?
Okay, so tonight we're going to talk about a very common skin condition. It affects a lot of people, and it's called rosacea.
Okay, and what's the molar rash?
Okay, so just a quick little disclaimer before we start. This video is for informational purposes only. If anyone does have any concerns, they should always seek the
Medical advice.
Exactly. Okay, so what is rosacea? So rosacea, as I said, is very common. Basically, it's redness of the cheek, the nose area. It can become very inflamed and red. People often notice that it starts out with a bit of flushing. So it commonly affects the age group of 30 to 60-year-olds, and they notice that they start with this kind of flushing, this going red. Like if you or I get embarrassed, then you go red. That's how it commonly starts. If it's left untreated, it can go on to form broken veins in the face, and you typically see this over the cheeks, and these veins can become broken, and it can even become more inflamed. And then if left further untreated, you can then get texture changes to the skin. You can get areas that are a bit more lumpy and more bumpy. We call them kind of papules and pustules.
Is that the ex-president of the United States,
yes,
Bill Clinton?
Yeah, so he actually has he has rosacea. He has what's called rhinophyma, which is basically when the nose, if you see here, the nose becomes quite inflamed and textured and bulbous, and that's one of the types of rosacea that people can get.
Right.
Mm-hmm.
Do you think he was treated for it, or did he just ignore it while he was a president?
Well, it probably got worse while he was a president with all the stress. So I say he probably was treated for it, but it definitely, I say, being the president of the United States didn't help. Certainly. But it's called the Celtic curse. So it's more common in fair skin, blue eyes, those of northern Western European descent.
But Celtic would be like some of the English and the Irish, isn't it?
Yes, English, Irish. A lot of Americans have it because a lot of the Irish and English went over to America, so it's very common over there, and a lot of the most up-to-date research and treatments would come actually from America.
Right.
Mm-hmm. So, if we move on to, so if the patient presents to us reporting any sort of facial redness, especially in the regions of the cheeks and the nasal bridge, one of the first things we think of is rosacea, but we also want to make sure there's not a few other things. So there's a couple of other things that we also rule out when we're kind of looking at a patient. First of all, especially with the more kind of textured form of rosacea, we want to make sure it's not an acne. So your doctor will often look very close to your skin. They might do it with a light and a magnifying glass, and they'll make sure there's no comedones. And that comedone is basically a blackhead or a whitehead. Rosacea will have no blackheads and no whiteheads. So if you see any blackheads or you see any whiteheads, that means it's more acne. It's more of an aggressive type of acne as opposed to rosacea. We'll also ask you in the history whether you've recently used any steroids, or if you've recently tried any new creams or anything that could have caused a flare-up of the skin. That's very, very important to ask. And if the history of the redness is kind of greater than 3 months, we'll also make sure that it's nothing like a seborrheic dermatitis. So that basically means that it's an overgrowth of yeast on your skin, and this is at the top here. So this top one here is what we call seb derm, and that's a yeast overgrowth. And we'll look at the qualities of what you're presenting with, and we'll kind of outrule that, because that's a different treatment to rosacea. With this, with a seb derm, we would be treating you with antifungals. We'll also look at the pattern. So if it's more focused around the mouth, we'd be thinking more of a perioral dermatitis. And this often affects a younger age group as well. If you look at this young girl here, it's more focused around the mouth.
So rosacea is basically a fungal infection.
Well, we'll get to that in a few other later slides, but yeah, it's not so much fungal. We actually don't know what causes rosacea. That's the interesting thing. But I have a couple of slides later on that we can touch on what we kind of presume are the causes.
So how do you actually treat it? What do you use for it?
So if we go on and look, so we'll click on to the next slide. Causes of rosacea, as I said, is unknown. It can be your genes and it can be in your environment. If we look at Bill Clinton, he was in a very stressful environment. Stress is a big one that can lead to these changes. Damage from sunshine. So if you have a chronic history of UV damage. They also...
So from the sun,
too much sun and a pale skin, blue-eyed, yes. They've also looked kind of at biopsies of the skin, and the skin is basically showing that there's something gone wrong with the barrier of the skin. So the skin defense system is a bit imbalanced. So you get too much vasodilation, too much kind of leaky vessels on the skin. So it's a skin barrier imbalance basically. There's also this mite that lives on all of our faces, so it's nothing to be scared about. It's called the Demodex mite, and this mite actually is found in increased numbers in rosacea. So we don't know whether it causes it or whether it just likes the environment that rosacea creates. And there's also steroids. So if you are on steroids for something else, steroids can provoke a rosacea type reaction in some people. Okay, so we'll move on to the next slide. This is a little slide just basically going through all of that that I've kind of mentioned already, and the genetic types that can predispose you, they find links to.
I can't wait to see the treatment.
I know.
How do you treat it?
Yeah, exactly. So first of all, the first treatment is to avoid aggravating factors. So what do you think some aggravating factors would be?
Sun exposure, maybe too much.
Yeah.
Emotional stress, maybe too much stress.
Yeah, definitely.
The hot weather, but I'd say that's for the white, pale skin, not for the darker skins.
Yeah, and you can see rosacea in darker skins. It's just harder to identify, so there's less kind of reported cases of it.
Obviously, alcoholics always have, and diabetics always have a red cheeks anyway.
Yeah, alcohol, definitely. So they would be the big ones: sun, emotional stress, hot weather, alcohol. Anything that really causes you, if you think yourself, what makes your face warm, like spicy foods, exercise. People with rosacea are often advised to cool their skin down after exercising. Cold weather, interestingly, the two extremes, cold and hot, can cause it. And then hot baths, hot saunas. People should definitely avoid saunas if they have rosacea. Hot drinks, funny enough, caffeine has been associated with rosacea, but they haven't proven whether it's just the actual heat of the coffee or whether it's the caffeine itself. And then some skincare products have been shown to provoke rosacea as well. Now, so this is a bit more in depth here. I don't know if we need to go into this much depth this evening, do we? On kind of the classification and grading of rosacea. Do you want to go into this much detail?
Yeah, you could, but just go a bit slower so everybody can understand your English.
Okay. So basically, if a patient comes and they have rosacea symptoms, we class it into 4 groups. The first group is called ETTR, and that basically is rosacea that is made up of broken veins. So broken veins or visible veins, and flushing with the veins and kind of a burning or stinging. So that's the first group of rosacea. You can have a second type of rosacea, which is called PPR, which is papular-pustular rosacea. And this is kind of persistent facial redness with kind of a tougher skin texture. So if you touch your skin, it'll feel tougher. It'll feel like there's little lumps under there. It'll feel hard. It's textured skin. Again, they may or may not have the burning or the irritation aspect as well. And then you have phymatous rosacea, which is called PR, and this is where the underlying glands in the skin have become enlarged, they're sensitive, they're tougher in texture, and you can actually get, if you look here on this gentleman here, he has the typical presentation of the nose, where the nose becomes enlarged with an irregular surface and contours. So that's the other sort of rosacea. And then you can also get rosacea of the eye, and the eye symptoms often predate the skin symptoms. So you might have a person come to you with gritty, painful eyes maybe 4 months before they actually present with skin changes. Okay. So yes.
Yeah.
So all of these different classifications are used to help us direct treatment. So
depending what type of rosacea you've got,
yes,
you've got a different treatment. Is that what you're trying to say?
Yes, exactly.
Okay, let's see.
Yes, exactly. So again, here you can see just how markedly red it is over the face, and this is a huge.
Just a bit slower, please.
Oh yeah. So it's a lot more redder over the facial surface here, and you can see the enlargement.
Okay, I see the nose and I can see the cheek.
Yeah, and it's
redder. What
huge...
type of rosacea is this now?
So this one is papular-pustular here, because you can see all the little bumps.
Papular-pustular. Okay.
Yeah, and this
PPR, is it?
PPR, exactly. And this one
Very
here,
good.
This one here is rhinophyma. So this is the nose starting to get textured and irritated.
So the oil glands.
Exactly, the oil glands, exactly, yeah.
Very good, very good.
Now, so
what's a malar rash? You never said what's a malar rash.
So a malar rash is over your cheeks, just under your eyes. Is that area, just your cheek, just on your cheek.
Is that the Bill Clinton syndrome?
No. It hasn't been called that just yet. But
that's what I'm calling it then.
Yeah. This area here, all of this area is your malar area. So it's basically the apple. So it's the prominent areas of your face is what rosacea affects. Kind of the nose, your cheeks, your chin, those areas. Now it's a huge emotionally kind of distressing thing for people. People find it affects their confidence. You know, it can lead to depression and anxiety.
Mostly for ladies, I suppose, or is it an equal in men and women?
It's probably more vocalized in women, but I'd say it's equally shared amongst men and women. Because your face is a very, you know, your face is what you present to the world. And people are very conscious of how they of different skin conditions that can affect their face. Now, so management. So this is a little mite that we were talking about earlier. So we all have them.
They live on our pillows, aren't they?
Yeah. Well, they
guys, Guys, so if you don't know, those things, microscopic things, they live in our beds, on our pillows, on our faces. They live everywhere. If you would have the eyes, the zoom in your eyes to see them, you would be amazed.
They particularly love living in your oil glands. So the oil glands on your face, they go down, they're down deep in there. So that's where they kind of thrive. Now, so the management of rosacea. If you have rosacea, it's definitely not something to be embarrassed about, and it's something that you should just make an appointment with your GP to kind of get sorted out and to get fixed. It's not something that you should have to suffer on with. Often people think that if they exfoliate it with like hard mechanical exfoliators, so like the kind of the apricot scrubs or the sugar scrubs that you can get in the pharmacy, often people come in and they'll have tried those like aggressive scrubs, or even the more the acid based scrubs, and all of that just inflames it more, and the more kind of oily, thicker creams they put on it, it's just, it can make things worse. So that your best thing is to go straight to your GP if you think that you have rosacea. From a doctor perspective, a doctor should never prescribe you a steroid for rosacea. In the short term, yes, you'll see an improvement, but what steroids do is steroids actually increase that nitric oxide on your skin.
So basically it gets rid of the redness for a short term, but actually on the long term it's actually bad for you, is it?
Yes, because the nitric oxide causes all of those blood vessels to increase even more.
So how do we treat rosacea then?
Okay, so there is no cure for rosacea. That's the first thing we tell patients. But it is highly amenable to treatment, and it can be very well controlled. Okay?
With what?
So the first treatment, if someone comes, so it depends on the type of rosacea. Okay, so if you come to me and you have a facial flushing rosacea, so that's the type number 1, that's the subtype
facial
number 1.
Facial flushing erythema.
Exactly. They have a lot of the broken veins, the visible veins on their cheeks, and they get it when it's not persistent erythema. It's more they flush every so often, and they get these like visible veins. Now, the treatment for this, the best treatment for this is a laser treatment. Okay, so.
But it says there alizac acid, solantra, dermatix.
So while you're waiting your laser, so it really is up to the patient at this point. Laser treatment is the best. Laser referral is the best option. You can try azelaic acid has been shown some benefit with facial flushing in the subtype 1 rosacea. And you can also try the treatment for subtype 2 rosacea, the solantra. Okay, so they are.
So what's solantra exactly?
So solantra is basically ivermectin. So that is a treatment for the mite. So it's an I'm not going to say anti-pesticide, but it's an
parasite.
Yeah, anti-parasite, exactly. So
because you treat head lice with that and scabies.
Yes, it's an anti-parasite.
And all those things.
Exactly. So the best, if you have facial flushing rosacea, if you look up here, this is a lady before and after laser treatment. This is kind of the facial flushing rosacea, this here. And it does. Oh no, sorry. This is actually the other cream. This is the brimonidine tartrate gel. Okay, it's also called Mirvaso. Okay, this is another treatment for facial flushing, but it's not permanent. It's only temporary. It lasts for a couple of hours. Women often use this if they have a presentation or something like that. Or
Did you use any today?
No.
All right.
It's for people with rosacea. But basically, the problem with bromidine tartrate, it works very well. It almost works too well. Sometimes people end up looking ghostly white.
Okay, but it's just temporary, so let's
It's only temporary, and people can get even redder skin afterwards. So the most effective treatment, if you have facial flushing, is laser.
What about the metronidazole gel there?
So we'll move on to the next type of rosacea. If someone comes in with the papulopustular rosacea, so what we looked at in the other side, the redness, the bumps, all of that sort of stuff, then you go in 100% with your Solantra. So this is the best one, first line.
So the one with the big papules and pustules,
yes,
they're probably full of mites, so then you want to kill the mites.
Exactly.
So you use your Solantra. Very
you
good.
go straight in there
then
with
you add azelaic acid because...
Okay, so you go in with your Solantra. If it's very severe, you can also add in an oral antibiotic. So you go in with a low dose doxycycline, not 100 milligrams, but actually 40 milligrams. Okay, so you're going to go for Solantra, an oral antibiotic.
But you skip the part with the metronidazole gel?
Yeah, so metronidazole gel has historically been the treatment that was used more predominantly so over the last couple of years, but Solantra is far more effective. So metronidazole gel, I wouldn't really be using it as much anymore. If you have someone who comes in with papulopustular rosacea, the best ones to go for, as per the evidence, is Solantra with an oral antibiotic.
Okay. Like what?
Doxycycline, 40 milligrams, low dose. Okay. And duration is normally 3 months for both. Some dermatologists will advise to use Solantra at night when the mite is actually coming out to the surface of the skin. So they come out of the pores onto the surface of the skin, wham on your Solantra, and that's kind of a good eradication of the mites. So some say use your Solantra at night. In maybe a month or two, when the Solantra has taken a good effect, you can actually then start some azelaic acid in the morning. So azelaic acid morning, Solantra at night, continue that for up to 3 months, take your oral antibiotic, and you should see a good effect with that after 3 months. Okay?
Yeah.
Now,
3 months, is it?
Yes, 3 months. Okay.
Oral antibiotics?
Yes. Mm-hmm.
Doxycycline 40 once a day.
Yeah.
And Solantra. And kill the mites.
Exactly.
3 months of the mites thing, is it?
Yes, 3 months, believe it or not. Yes. So it's something that needs to be persistent and needs to be dedicated.
I would use it every day to kill the mites on my face.
I know, best to use it at night though. It's interestingly the mites come out at night. So rub it on
what
then.
If you don't sleep?
They'll still be out in the dark. They'll still be like munching away. So
I'm gonna sleep with my lights on from
now on. Okay. Now, if you look at this gentleman down the bottom, we can see here the rhinophyma. The advice for this is actually, so what you're talking about, the metronidazole gel. So rhinophyma, metronidazole gel, laser or surgery. So
when you have the bumps on your nose,
mm-hmm. Evidence is saying to go for the Rosacea gel with some laser or surgery. Really, they often...
Which gel, sorry?
The metronidazole.
Okay, antibiotic gel.
Yes, antibiotic gel, and refer them straight away for laser or surgery. It's not really something that's going to fix with some creams.
1 second. So rozacea, dacă ai pielea iritată, doar te duci la laser. Dacă se umflă niște bubițe pe tine, înseamnă că ai viermii sau paraziții mici, care se numesc mites în engleză și trăiesc în perne și în toate astea, și atunci ea trebuie să-i tratezi cu crema aia. What's the name of that cream? Solantra.
Solantra, yeah. So this is a lovely slide.
Deci depinde ce tip de rozacea ai. Bill Clinton avea doar că se înroșea fața de la stres. Bill Clinton needed only laser therapy, correct?
Yeah.
Laser, okay.
So this is a lovely slide. If you have any questions, if you think you have rosacea, take a picture of this and bring it to your doctor. And it actually discusses all of the treatment options. So as I was saying here, it has all of the treatment options again. So if you have this flushing rosacea, it tells you that these things are good. So here's the laser. So intense pulsed light laser or pulsed dye laser. So the best laser actually is a PDL. So if you have rosacea, look for a PDL, look for a provider that provides PDL. Now all these laser therapies are private, so they are pretty expensive.
How much? Do you know?
So 6 sessions can be up to €1,000.
€1,000 for 6
€1,000 for 6 sessions. Yeah. So laser does not come cheap, and unfortunately the government doesn't recognize rosacea as a treatment. So
it's more like, well, the facial flush one is probably more like an aesthetical treatment.
Yes,
but
exactly.
What about the PPR or the other ones?
So with the pustular ones here, if you look at all the little crosses here, which is saying all the treatments are good, we have our cilantro up the top, which is the best thing to go in for.
So
for 3
the
months.
government just says give the cream, is it?
Yeah, you can get the creams on a medical card, so that's no problem if money or anything like that is a problem.
Yeah, but the first one, what can you do for the first one? Was cilantro worker in the first one?
Yeah, so it's hit and miss. Some patients say it does work, some patients say it does nothing for them. It's always worth a shot if you can't afford laser.
Because on the first one they said, laser therapy would be the most.
Exactly. So as you can see here, the PCDS recommends laser as the best option.
For which?
For the flushing.
Where does it show that?
So do you see?
Where's the laser?
It's down here. So don't bother with the IPL. Go straight to the PDL that's shown the best results in.
PDL meaning?
Pulsed dye laser. So it's much stronger than IPL.
So it's more than a light, it's actually a beam or something?
Yeah, it's much stronger, it's much more effective.
But it's also a light, like a flashlight? Or?
It's constant, so from what I was reading on it, it's a constant beam. And intense pulse light, IPL I think is more...
IPL is just like a flash, like
exactly.
take a picture.
Pulse dye laser is a constant.
When you go and get yourself waxed, that's IPL.
Yeah, so pulse dye laser is a constant beam, so it's a lot more effective.
Is it more dangerous to the skin, do you know? Or?
Yes, the people do
can
actually...
Can everybody have it? Like white skin people can have it?
So you'd have to discuss it with the who's ever given it to you. But people do, you end up with a bruised face for a week or two after it, so it is quite intense. People have actually enjoyed now that you have to wear masks during COVID, because they can go for their laser sessions and they can just pop their mask on.
Yeah, very well.
But the people have found that their rosacea is actually improving with the mask because their skin is protected from the cold and the heat. So it's quite funny.
And you can also not see it.
True, exactly. So that's this slide I think is great because it just lays out everything very nicely and very neatly, and you can see what you want to kind of discuss with your care provider. Okay, so we'll move on then to preventative measures. Okay, so what we'll say first of all is we'll go on to when to consider referral. Okay, so if a patient is in severe psychological distress, I would refer that patient to dermatology. They'll need kind of regular follow-up and better management that can be provided from a dermatological perspective. If they haven't responded to the treatment that you've given them, if after 2 or 3 months they haven't responded, refer.
So sorry, who gives that? The GP?
No, dermatologist.
So where do you refer them?
To the dermatologist.
Oh, you mean you give the cream?
Yeah. What cream?
So you said if they don't respond for 2-3 months.
Yeah. So you've given them the cream, they're not getting any better, refer them on.
Obviously.
Yeah. And
because the cream is for 3 months. You said that already.
Yeah, and
so we gave the cream for 3 months. Now working, obviously, have to refer to laser therapy or IPL or DPL.
Perfect.
PDL,
Perfect. Exactly.
Logical. Sounds logical. Okay.
Yeah, and always remind them as well that laser fades. So laser only lasts for 3 to 5 years.
It comes back, is it?
Mm-hmm.
So what do you do then?
You need to continue topical therapies. So when you get a flare, so rosacea is a condition. It's called a chronic inflammatory condition, and that basically means that it reoccurs. The inflammation reoccurs. We don't know.
So basically, you burn the superficial veins that are causing it, and then they grow other veins. Is it?
Precisely, yeah. So when they flare again, they'll need topical therapies and
burn again.
Exactly, and after 3 to 5 years, they may need to return for more laser.
So why? You do it all your life, is it?
It is. That is what you need to discuss with the patient. Some patients do recover and they get a good kind of suppression of the rosacea. Other patients flare for different reasons. So it's a combination of...
But one question, why is the steroid cream making it worse though? Because the steroid is an anti-inflammatory.
Yeah.
Why is it making it worse?
Steroids increases the locally the amount of nitric oxide. And what does nitric oxide do? It feeds blood vessels.
It feeds?
Feeds blood vessels. Nitric oxide dilates and opens blood vessels. So steroid increases the amount of nitric oxide on the skin. That increases the dilatation and also the growth of blood vessels on the skin. So yes, you do get an immediate anti-inflammatory effect of steroids, but you also will get the rebound, actual worsening and more aggressive.
So you just have to tattoo on your face Solantra.
That is one thing. There are other kind of preventative measures that people can do for themselves. So look at their diet, diet rich in kind of good fats, avocado, salmon, nuts, low in processed sugar, things like that. Look at the
healthy food, you mean?
Healthy food, exactly. We can't be healthy all the time, but 90% of the time, 80% of the time, try look at your diet. Look at what you're putting on your face. So go for products that are alcohol free, non-fragrance, and non-foaming. Okay? Never use a toner on your face. No one should ever use a toner on their face. Use a gentle...
What's a toner, sorry?
A toner is what women use. It's kind of like a liquid... There's so many of them on the market. It's a clear makeup remover, basically. But it's very abrasive, very hard, and can often be full of a lot of alcohol and drying things. So avoid toners.
So it's to remove the makeup, is it?
Exactly. Get a gentle pH balanced cleanser. There's really good ones on the market. Cetaphil, I have pictures here. So Cetaphil
is that like a white
cream,
milky cream? Yeah.
Exactly, yeah. So Cetaphil, CeraVe, La Roche-Posay, Dermo have really good ones that are all good for rosacea. And then hydrate with things like
not to flare it up, you mean? Not
exactly, yeah. You're looking to dampen everything down. Don't be putting on your makeup with brushes that are kind of itching the surface of the skin. Always use a sunscreen. So UV is an identified cause of rosacea.
What factor?
30, minimum of 30. Mm-hmm. And go for your natural sunscreen.
But do you know there's a myth actually? It doesn't matter what SPF factor you put, you still get tanned. Do you know that?
Well,
it's a myth that you don't get tan if you wear a higher factor.
Yeah, so you
still get tan, you just don't get burned,
Exactly, yeah. Exactly. So the sun factors I'd be recommending is the natural based ones that are made of zinc and titanium. Avoid anything made of oxybenzone. Okay, there's a good one called Elta MD. So if you're looking for a good one that's for rosacea, Elta MD is a clear sunscreen. It's zinc, I think it's zinc based. So it's one of the better ones.
Is that a zinc and titanium, is it?
Yeah, a mineral based. You're looking for a mineral based SPF, nothing with oxybenzone in it.
Titanium and zinc sounds like Iron Man.
So it's good for the face. If you're a man and you have rosacea...
What's oxybenzone anyway? It's like acid, is it, or what?
Oxybenzone...
Oxide. It's an oxide.
Yeah, it's a chemical basically
so
that...
an oxide would be like rust, isn't it?
Yeah, it's a chemical that irritates the skin. So go for the natural ones. If you're a man, shave carefully and don't use those burning creams on your face that, you know, make you...
What burning cream? I don't know what that is.
Well, what men tap on their face after they've shaven.
It's like a balm.
Yes, don't be using any of those things.
Right. So what is that? They're supposed to calm down the face.
Yeah, exactly. You're supposed to calm.
No, but those balms are actually calming down.
Well, if you can get one that's alcohol-free, fragrance-free...
Alcohol-free, fragrance-free, okay.
Then you can go ahead with it. But I would be avoiding anything that's inflaming kind of an already inflamed face. Oral vitamin B3, which is called niacinamide, has actually been...
B3, is it?
Vitamin B3 has been shown...
Bravo.
Bravo, B3 has been shown either orally or topically in studies to have anti-inflammatory effects on the skin. So that's something to look at as well. You can get them over the counter in the pharmacy. And then always just, if you're kind of changing up your skin care regime, change one thing at a time so you can actually identify what's working and what's not working. And cosmetic camouflage. La Roche-Posay has some good kind of creams that you can use as...
Why are you supposed to use non-mechanical exfoliants like aspirin?
Okay, so non-mechanical exfoliants, yes, exactly. So the one that's advised most by dermatologists is BHA based, so salicylic acid.
Yeah, that's aspirin.
Yeah, so never, it's more gentle on the surface of the skin. So often these patients will actually, they'll have oily skin, but they'll also have a lot of dry skin on top of it. So a gentle exfoliant every so often, you know, once a week maximum is enough.
Is that preventing the rosacea from flaring up, is it?
Yeah, it will stop kind of the build-up of skin. It will just, if you want to use an exfoliant...
Well, I think everybody should use it then.
Yeah, use the salicylic acid as opposed to those aggressive sugar scrubs, those apricot scrubs, all of those really hard ones.
Let me just mention it again, which is aspirin actually. Aspirin. The cheap aspirin.
Yeah.
Powder.
So that's really everything on rosacea for this evening. The other thing is we discussed about the referral, and then this is just ocular rosacea. So this is just an aside. So it's something that can present, like people with rosacea can get dry, irritated, gritty eyes.
Oh my God, and you think it's an infection of the eyelid or something.
Exactly, but it's actually...
Like a periorbital cellulitis.
Yeah, but it's actually just ocular rosacea. So the treatment for this is actually the P-odoxycycline. Lubricating...
So 40 milligrams for 3 months?
I would need to check whether it's that dosage for ocular rosacea, but it is P-odoxycycline. Lubricating eye drops or aqueous gels, any of them, there's a ton of them.
Lacrylube or things like that, is it?
Exactly. And then just good daily hygiene. So it's about kind of wiping away all of this crust, all of this build up along the eye gently with some sterilized water and warm water and some cotton pads. So you're just good eyelid hygiene. Now there is something to watch out for with ocular rosacea. You can get corneal abrasions or ulcerations. So if you notice any changes on the inside of your eye, any difference...
So if I have red around my eye, I need to go to the doctor, basically.
Yeah, if you've any change in your visual acuity, you need to go to a doctor, exactly. You need to go to a doctor with this anyway to get the antibiotics and to get treated.
So, dacă ai roșu la ochi, mergi la doctor. Dacă ai roșu pe față, mergi la doctor. Dacă ai roșu pe nas, mergi la doctor. Orice în neregulă cu tine, fugi la doctor să-ți dea ori crema, ori antibioticele care trebuie să ți le dea.
Yeah.
Just a quick translation, apologies.
No problem. Yeah, so...
Just for the chat, so.
So that is really...
So can you go again? So just say the title, Rosacea.
Yes.
Just put it on, the title, the first one.
So this is rosacea. It's called the
So, rosacea in Romanian.
Oh,
rosacea.
Right. So rosacea.
And what's the malar rash? Tell me that. The redness around beneath the eyes, around the nose there.
Yeah, so it's where your cheeks are, your nose. Some people.
Când ai roșața aia sub ochi, între nas și sub ochi acolo, stânga-dreapta.
Yeah.
Așa o vezi, roșața aia.
If we look at this picture, this lady has
that thing can appear with alcoholics and with diabetic people as well, correct?
Yes, yeah. So there's lots of different causes.
Diabetici și alcoolici au aceeași chestie, and that's different to rosacea, correct?
So it's very hard to say whether it's different or whether these people just actually have rosacea. Because the provoking factors for rosacea are alcohol. So alcohol causes facial flushing.
But I don't see anything about diabetes there.
So diabetes can get it, but they might just have rosacea, and it might just need to be treated.
Because that's the first time the sugars are high in somebody and he's diabetic. You see that sign on the face, like rosacea.
So if it's flushing and if it's causing veins or broken veins, then that is technically rosacea, and it technically does need treatment.
Okay, so
if the person wants to treat it. But if it's just like you're flushing because you're in an embarrassing situation or anything like that's not rosacea. So it's things that are recognized to be provoked by aggravating factors.
I'm just going to add something that maybe will help. So researchers shortly found a possible relationship between rosacea and insulin resistance, a metabolic disorder that may be a precursor to diabetes. So there is a connection between diabetes and rosacea, but it's not a direct one.
So there you go,
between rosacea and some elements of metabolic syndrome. So that could be obviously connected to metabolic syndrome. Do you know about metabolic syndrome?
Yeah, so metabolic syndrome is basically when your sugars are high enough in your blood that they aren't normal, but they're not high enough that you're diagnosed with diabetes. So you're kind of in that in between, you're in that gray zone where if you make lifestyle changes, you can actually reverse the effects. But if you continue on the same path, you will end up going towards diabetes.
High blood pressure and obesity.
Exactly, yeah.
That's the metabolic syndrome.
Yeah.
Puts you at greater risk of getting coronary heart disease.
Yes.
MIs, probably strokes and other conditions that affect blood vessels.
Yeah, exactly. And I just want to talk
let me just quickly translate.
Yeah.
Deci, ea este cumva legată indirect de diabet și de sindromul metabolic. Sindromul metabolic înseamnă că ai glucoza ridicată în sânge, dar nu atât de mult încât să fii tratat pentru diabet. Ești obez și în același timp ai blood pressure, tensiune mare, arterială. Și atunci toate astea la un loc te pun într-un grad de risc mai mărit pentru infarcturi miocardice sau atacuri vasculare cerebrale. Okay, you can continue, please.
Yeah, and then this is just a little an aside. So if people are wanted to go to their doctor with a rash on their face, so sometimes doctors will have prescribed steroids for the patient for various reasons. So this is the steroid rosacea, what you were asking me about earlier. So these are actually people who have all been prescribed steroids for their face and have had some sort of a reaction. So always
steroid creams, let's say hydrocortisone.
It would have to be something that's slightly more potent than hydrocortisone.
Okay, Bednovate, Humovate,
yes,
which ones?
Yes, exactly. So
okay, betamazone, okay, something like that. Clobetazone.
Yeah.
Okay.
Yeah. So basically, we always ask patients, have you been on steroids? Because this is what can happen. And actually, how we treat that is we'll give you the doxycycline, and we'll discontinue the steroid.
So antibiotics.
Antibiotics, stopping the steroid, yeah, and
do you give, what's that with Lamisil and Miconazole?
So this is just another thing. So see this man here, it looks like acne. Would you agree that looks like acne?
Not really. I'd say it's more like
what would you think?
tinea.
Yeah, exactly. So it's tinea barbae. So it's beard. Beard.
So that's more like fungal.
Exactly. Exactly.
Ciuperca.
So if you put steroids on this, it will get worse. So this man here with his forehead, he had tinea as well, and he was treated with steroid, and he actually ended up with a floridly red face. So we are always on the lookout for whether something's
Lamisil is
antifungal.
Terbinafine.
Yes, exactly. Terbinafine, exactly.
Terbinafine.
So this is more tinea
and
here.
Dactylene is miconazole, isn't it?
So if you look at these faces here, this is all tinea. This is all tinea. So we never ever treat with a steroid. We always treat with a topical antifungal. So if a patient thinks they have something like this, say to your doctor, if they try to give you a steroid, say an absolute no. It will make things definitely worse and more inflamed. So topical antifungal. So they're just things that can often get confused and mixed up in the day-to-day consultations. That can have a big impact on kind of the well-being of the patient.
So it's good to talk about them, remind ourselves from time to time what's that, so we try to keep the errors as low as we can.
Exactly. So better patient satisfaction.
That thing, that lady, there's a lady there on the screen. I can see a big, like a ringworm, like a fungal infection on her chin. I think that's clearly fungal-like.
Oh yeah, that's clearly fungal. Yeah, that's got the lovely kind of...
That needs the Dactylene straight away.
Yeah.
Would you give actually Dactacor there?
You'd be surprised though. Yeah, definitely. So Dactrin, yeah.
Would you give Dactacor because that's got a bit of steroid in it?
No. You'd stick with the terbinafine, miconazole.
Because fungal infections are masked by topical steroids, so the redness would go away, but it's still fungal infection.
Yeah, well, Dactacort wouldn't be the worst one to try, but if you've seen that kind of lace pattern, that's a lovely...
That's clearly fungal.
Exactly.
You
so
you can't miss that.
I would go in straight with terbinafine for 2 to 4 weeks. But there's been people who have gone to doctors. They've said, "Oh, I actually think this is ringworm," and the doctor has given them steroids, and they've ended up worse. So,
well, probably the redness went away for a while, and then the bacteria still kept on eating the skin until it made a wound or something.
Yeah.
And then you required both antifungals and antibiotic.
Yeah.
And then one contracts each other, and that's hard to heal.
Exactly. Yeah. So it's kind of this vicious circle.
So can I see the first slide again?
Yeah, which one is that now? Rosacea?
Title.
That one?
Yes. Well, thank you very much, Dr. Y, for your presentation today.
I hope
it was helpful. A pleasure talking to you.
Oh, thank you. Thanks again for having me.
No problem, Dr. Y.
Thank you. Bye-bye.
I wish you all the best. You can please stop streaming on your OBS, no problem.
Perfect. Okay.